Hello there! So, MRI is fun, my queue is full of new exams. Why don't we go through a few cases from the clinical history all the way to the report? I'm going to share my screen and we're going to have some fun. Let's get started. So, let's get to the first exam. This is a brain CT scan of a 73-year-old male patient. It's a brain scan and a neck arterial angiogram, and it says he had a stroke. So this is a stroke follow-up. We have here a humongous quantity of sequences. This is a sagittal volumetric 3D flare. Flare is a T2 weighted image that has a additional recovery, impulse recovery, IR pulse that saturates normal brain fluid, so ventricular and subarachnoid fluid is black. And I can readily see that they also added a inversion recovery pulse to saturate fat. So the sequence saturates normal fluid and fat, so it's all black, and it is weighted towards fluid signal, so we can see bright spots of disease if they are present. So I can see this is gliosis and this is malacia. So this is dead brain tissue and scarring. This is a scar of a stroke in the occipital right occipital lobe. This is the territory of the posterior cerebral artery. This is a stroke scar, and flare is a great sequence to look for pathology, but T2, regular pure T2 and T1 are best for anatomy related issues. So there is anomalous fluid on the right mastoid cells. This is probably a acute mastoiditis, which is very common in elderly patients. They even complain of dizziness and nausea and pain, and people think it could be a new stroke, and it's all infectious disease of the middle ear and the temporal bone. So we can also see the lateral and third ventricles are a bit enlarged. Also, there is quite some widening of the sulci, especially supratentorial sulci, which points to some degree of brain atrophy. So there is reduced global volume of the brain parenchyma, which is expected for 73 years of age. So let's see, this is a MPR reconstruction because the original acquisition is sagittal, because this is a volumetric acquisition. This is very common because acquiring a volumetric sagittal image on MRI on a brain MRI is much faster than if you do it on any other plane. So you can always do an MPR if the sequence has been done properly, and this is a very nice looking sequence. You can see the malacia and the gliosis the occipital lobe on the right, and they had also a axial 3D T1 acquisition, which makes no sense, but they did it. So this should have been also a sagittal acquisition to save time. I believe this place has a really new MRI scanner, and they should make a lot of money out of it, because they surely don't care about exam time, exam duration. They are pushing it towards making very, very good looking and time consuming exam. So in a T1 weighted image, malacia and gliosis have a reduced signal intensity like this. This confirms we have a case of chronic stroke. This is a scar. This isn't new, apparently. Also, we have almost no signs of chronic white matter disease. So this patient has a good looking brain for his age. Unfortunately, he had a stroke. And this isn't really the most common stroke. The most common stroke is a middle cerebral artery stroke, and he had a much less frequent stroke, a right posterior cerebral artery stroke. So let's see a hemosiderin oriented sequence. This is a SWAN sequence. This is a sequence oriented to artifacts, susceptibility, magnetic susceptibility artifacts oriented sequence. This is supposed to catch mineral deposits and blood deposits on all kinds of lesions. As you can see right here, we have some lower signal small areas on the margins of the stroke area. This is very common because this is a large stroke. It has a bit of hemosiderin deposits on the periphery. So this is what it is supposed to look like. Also, the choroid plexus are partially calcified. We have a tiny hemosiderin or mild calcification on the bones. Clearly normal. Lobe pallidum is also affected. It's really common at this age. So we also have a T2 weighted image. It makes the malacia and gliosis much more apparent, much more easy to see. And the rest of the parenchyma indeed is normal. Also the mastoiditis is much easier to notice in the sequence. They also added the fat suppression pulse to the sequence, which isn't needed. You only need one fat suppressed T2 weighted sequence on such an exam. But as I said earlier, I think this place has a very new and powerful MRI scanner, and they really don't care about exam times and exams taking too long to finish. So they should be making a lot of money. This is a coronal MRI excision. This is a inversion recovery IR sequence, a T2 weighted sequence to check for the morphology of the hippocampus and the medial mesial temporal regions. Hippocampus and amygdalas are fine. Temporal lobes looks symmetrical. This is a very old patient with perfect hippocampi. So it's awesome. He is unfortunately he has unfortunately a stroke scar on the right. So this is a diffusion weighted sequence that should have its very peculiar ATC map sequence somewhere here. No, they didn't send it. Did they send it? Yeah, they sent it. They have sent it. They sent it. Oh, so this is the ATC map, and this is the diffusion weighted sequence. So it's really a chronic stroke area. It's very dark in diffusion and very bright on the ATC. If we had a acute stroke, we would be able to see bright areas on the diffusion weighted image and very dark areas on the corresponding sites on the ATC map companion. So we have no signs of acute stroke, just a scar of a previous stroke. So, hippocampus are fine, and we can report this exam. Oh, they say here they had a contrast enhanced phase, and they do. They have a volumetric post-contrast acquisition, which of course takes a lot, and the patient always moves a bit. So there are some movement artifacts. Contrast enhancement in such cases of stroke follow-up are not needed, so this is a spurious sequence that took a lot to be acquired and has no additional information for us. But it looks nice, and I think you guys are enjoying this beautiful looking MRI scan of the brain of this patient. So let's report it very quickly. This is a nearly normal MRI scan, contrast enhanced. We only have to say there is mild brain volume reduction and some enlargement, symmetrical enlargement of the ventricles and that area of a previous stroke. Malformation gliosis area has been reported. Now I'm going to say there is widening of the cisterns and sulci all over the place, especially supratentorial. And there is also the dilatation, widening of the lateral and the third ventricles. Mild. We've got it. I'm also add that bit of hemosiderin deposits on the area of Malaysian gliosis. And I'm going to summarize the report to make it easy for reading, so the referring physician is happy when he gets this and just reads a few words and knows what the report is all about. So let's get back to this exam. We have to see contrast enhanced phase is fine. We were already reporting it. Now I remember. So hippocampus are fine. I'm just going to summarize the scan now. And it's done. It's a common follow-up of a stroke patient, nothing major. So let's finish and sign it and go for the angiogram. So it is a cervical angiogram, arterial, cervical, arterial angiogram. Here it is. It's contrast enhanced, of course, because contrast enhancement makes a complete difference no matter how great is the scanner. Contrast enhancement for arterial MRI angiograms is always the best choice, because the neck is a brutal place to scan. So let's go for the coronal view, because this is the original view. It seems there is some atherosclerosis of the carotid bulbs, especially on the left, which makes no sense in this case because the stroke is on the right. But what do I know? Let's hit an MPR button and look for disease on the best plane of all, which is the axial plane. Real men read axial images, children do MPR. So we are children, we are men. So yep, there is a small plaque, a atherosclerotic stenosis, mild atherosclerotic stenosis right here on the left carotid bulb, right before the bifurcation, that has almost no repercussion. We can do a direct measurement to classify this stenosis. 1.1. This is an ACT scan, so this isn't the best way to do it, but we can say that this is above 50% and below 70%. So that is a 50 to 69% stenosis. It is significant. It matters. So we are going to report it. Also, if you measure, let's do a sagittal. Is this sagittal? I guess this is sagittal. Yep, this is sagittal. If we think of this as a digital angiogram. We can measure the distal carotid artery on the sagittal view. It's 5 millimeters, and we can measure the stenosis. The stenosis is really tough, really difficult to measure on this view, so I'm going to try to measure it on the coronal view. This is where the stenosis really shows itself, so it's 5. So there isn't much to be worried about. The stenosis is a 5 to 5. So if we use this criteria to measure it, it isn't relevant. But I always prefer to do a direct measurement, so we can be more accurate and the measurement can be more easily reproduced. So vertebral arteries are fine, a bit tortuous, but fine, as they always are. Signal intensity close to the origin of the vertebral arteries are usually bad, low, and can be quite confusing. So, but all in all, it seems fine. Subclavian, brachiocephalic trunk seems fine also, and the carotids are also as preserved as they could be at age 73. So let's just describe that mild stenosis and get on with our exams. So described as a 50 to 69 stenosis on the left carotid bulb, and this is it. Just saying that the vertebral arteries are tortuous and saving it. So just summarizing quickly to make it easier to read. And tortuosity of vertebral arteries. And we are done. So let's clear the cache and wait for the system to sign off this exam and report a few more. So it's done, it's reported. Let's grab something else so you guys can see other stuff besides brain scans. Now let's get a lumbar spine MRI of a 37-year-old female patient. She says she has bilateral lower back pain, so we believe her. That is a very common complaint. Let's grab a template as the images are downloaded so we don't waste much time. The template has been set and we are currently recording. Everything is fine. The images are downloading. Just a few seconds more. We are done. Downloading is done. So since this is a very young patient, we are most probably looking at a case of a normal scan. So this is a sagittal T2 weighted image. There is no fat saturation because fat is bright, so is liquid. So spinal fluid is a bit brighter than fat, which means this exam was very well made, and the images are very good looking. It is a great new well calibrated scanner. As you guys can notice, it seems discs are normal, so are bone structures, bodies, and posterior elements of the vertebral bodies. The vertebral elements, I can see a small meningeal cyst right in the sacral canal. The nerve roots are okie dokie on both sides. There are no protrusions, no bulging discs whatsoever. There is no sign of a transitional vertebra. We could say there are some very mild osteophyte formation, but I wouldn't go that far. This is quite normal, so let's keep it normal. The perivertebral muscles are maybe a bit hypertrophied, some hypertrophy and fat infiltration, but considering this is a overweight female patient, this could be just to the body mass, the fat composition of this particular patient, not actually represents chronic denervation of the muscles, especially because the spine has no signs of degenerative disease until now. So let's get a T1. T1 is bright fat, low signal, liquid fluid. So this is a T1. It is great to see bone and morphology and arthrosis and nerve root surrounded by fat. So this is really fine. This is awesome. No signs of disease. No, this is a STIR, a STIR sequence. This is a T2 weighted sequence that has a recovery pulse, inversion recovery pulse to saturate the signal of the fat signal, make it dark gray like this, and enhance any abnormal fluid, edema, tumor, or infection. So we can see the meningeal cyst is here. This is benign, makes no sense in reporting because it's very far away from the sign of complaints, and it is asymptomatic almost 100% of times. There is no inflammatory sign on the posterior ligaments, nor there is any sign of synovitis of the facet joints, which could justify painful symptoms. There is also no signs of bone edema, which is very uncommon. I thought we could tell by reading this exam why the patient complains about lumbar pain, lower back pain, but this is indeed a normal MRI scan. So let's just say it's normal and go to the next exam. Now we just grab our template and finish by summarizing it, saying it's normal. So it's signed, the cache is cleared. Let's go for the next one. So this was a normal spine, lumbar spine exam, and we are facing a very sluggish platform today. It got better, so let's go for a brain Venous angiogram of a 37-year-old female patient. Let's download it. So a MRI angiogram of the brain. I have a template for it, of course. This is usually to search for dural sinus thrombosis. Let's see how fast it's downloading. It's downloading quite fast. We only need to wait for a few more seconds, and we are going to report it. So let's see if there is any clinical history for this case. Let's see, clinical history is loading, and it's taking way too long to load, and it's loading once again. So it says she has intracranial hypertension, obesity, and some hypertension, something wrong with her right eye. So they are probably looking for thrombosis, acute thrombosis. She has gone through a brain scan that has turned out to be normal. So the regular brain scan was normal, MRI brain scan, and they are now looking for vascular diseases, so thrombosis. So T1 sagittal, normal T1 weighted sagittal image of the brain, and acute thrombosis should be a bright spot on a site that has acute bleeding. There is no such sign. It right here on the joining of the sinus. They repeated the entire brain scan and then did a angiogram, which makes no sense. This is just to waste time. Oh, they have a susceptibility artifact oriented weighted sequence, volumetric axial sequence, a SWY or SWAN sequence, which highlights blood products both acute and chronic. So there isn't any signs of blood product hemosiderin deposition or acute bleeding on this particular sequence, which is fine. Also a T1 axial view of the brain. I can see there is quite a reduction in size of the pituitary gland, What caused it, I have no idea. And we have a pre-contrast volumetric sagittal T1 weighted gradient echo sequence that is used to subtract from the post-contrast the contrast enhanced phase of the same exam. So we have the sagittal major and minor dural sinus, the posterior fossa sinus, both sigmoid and transverse. We have the confluence of the dural sinus. We have the cerebral magna veins, the rectum sinus, the straight sinus, and cortical vein seem fine. These are not thrombosis, these are arachnoid granulations, these are normal. The major cortical vessels seem fine, and we are going to hit the MPR button and look for thrombosis of the other sinuses. Yeah, it's fine. It's always good to check vascular pathologies in more than one plane, because sometimes we just miss a important feature, or we miss a acute thrombosis altogether because we didn't care to check on more than one plane of view. So as we can easily do MPR reconstruction, so why not? These are the cavernous sinuses and the parietal sinuses and temporal sinuses, petrous sinuses, both superior and inferior, are all fine. The internal veins are fine. The straight sinus are fine. It's all right. There is some minor asymmetry of the sinuses. This is really common. This isn't disease. The sinus aren't supposed to be symmetrical. They are supposed to be alike. They are similar. They are never identical. So this is a normal brain venous angiogram. So let's go for normal. And let's finish this report and go to the next one, because as you guys know, these exams won't report themselves. And I just remember, if you haven't already, hit that like button and consider subscribing to this channel. Thank you so much. So this is fine, this is cleared. Let's grab another exam. So let's get a lumbar spine once again. This is a lumbar spine, lumbar MRI scan of a 36-year-old female patient that says, let's see what she says. She said on her questionnaire. What is she feeling? I have a tiny bit of coffee left. It's cold and it's awesome. She says, let's see. She says she has lower back pain, and some inflammatory markers are high, and yeah, that is it. Some kind of odd, strange lumbar pain. Let's see, let's load the images and see if they have done it right. I don't think they have. Oh yes, this is it. So we have a coronal view, a coronal T2 with fat saturation. That makes no sense because this is a useless sequence, but it looks good. It's nice to show off and usually useless to report. This is a sagittal view. This is a pure T2. There is no fat saturation. Liquid fluid, spinal fluid is bright, and fat is bright, but just a tiny bit less bright than fluid. So this is a well done lumbar spine CT scan. There is some degree of degenerative disease of these discs. They are reduced in height and in hydration, in T2 signal intensity, especially on L5S1, the last of the lumbar segment, the transitional segment to the sacrum. Is there any sign of transitional vertebra? Let's see, this is the last rib. So this is L1, L1, 2, 3, 4, and 5. No transitional vertebra, but as you guys have already noticed, there are some bulging discs. There is a bulging disc on L4, L5, and also a bulging disc on L5, S1. And clearly there is foraminal stenosis right here, and the nerve root is compressed against the bone by the disc and the ligament, so this is painful. Also on the other side we can see the same. I'm just going to close this, make a close-up so you can see better. So this is the nerve root and this is the disc, and they are touching each other. This is quite painful, and this is also quite painful right on the other side. So if the patient feels pain, as she says she feels, she does, she has she has two motives on each side to feel pain. In L4 and L5, that protruded disc also touches the emerging nerve root, especially on this side, which I believe is the right side. I'm just going to check it by comparing it to the axial view. So this is left and this is right. So unfortunately this exam was scanned from right to left. It is usually scanned from left to right, but this isn't it's more of a agreement than a obligation. So sometimes the technician scans from right to left and not from left to right. It's okay, we have the axial plane to compare. So we have a mild stenosis on the left side of L4, L5, and mild stenosis on both sides of L5, S1. Let's just see right here. This is oriented wrongly. This was supposed to be oriented like this. So images will be distorted, especially on this transitional segment right here. So this wasn't the scanner is great, but the technician not so much. So they also used contrast enhancement, which makes no sense, but it was requested by the physician, so they did as requested. So contrast enhancement is unremarkable because it is supposed to be unremarkable. There is some enhancement on these facet joints related to arthrosis and some kind of synovitis, which is quite common, and we can readily see this on the STEER images. There is no need to actually use contrast enhancement. So this is a STEER, a fat saturated T2 image. This has a lot of extremity artifacts, coil extremity artifacts, because it was used a large coil, not a proper coil for the spine, and the field of view is way too large to make the acquisition time smaller, shorter. So they are using here techniques to make the images look like crap and the examination go faster. But as we are used to this, and we have reported thousands of exams just like this and even worse, we can easily just go through it without much trouble. So there is arthrosis, mild arthrosis of the facet joints, as expected. So mild arthrosis, there is thickening of the yellow ligaments. Yep, they are thickened. No vertebrocoronal stenosis, and the nerve roots are fine. No signs of neurological intravertebral intracanal disease. Nerve roots, emerging nerve roots are just fine. Yep, it's okay. It's just degenerative disease. Arthrosis, some protruding discs, some mild foraminal, neuroforaminal stenosis. This is a very, very common diagnosis for a day-to-day routine reporting MRI scans. So on L3, L4, I can also say there are some tiny protrusions right on the foramina. So can also say, but there isn't any sign of impingement of the emerging nerve root, so there isn't stenosis on this segment, just on L4, L5, and obviously on L5 as well. So let's grab a template and get on with this report. So this is it. Is the hypertrophy of muscles. Very, very mild. I'm going to let it pass. So let me grab a proper template, because templates help a lot. And small osteophytes. Oh, small osteophytes are there. There is chronic dehydration of discs. Yep. And we have on L3, L4 small foraminal protrusions, bilateral. also on L4, L5, but they are bigger and larger, much more easy to see. So they are right there. Yes. I'll just group together L4, L5 and L5, LS1. So let's, there is arthrosis, degenerative disease of the facet joints, mild, and stenosis. Right, left L4, L5 foramina and bilateral foramina on L5 as well. And the rest is fine. And the conus medullaris is well put. Morphology of nerve roots is fine. And I know you guys are screaming on your chairs because I didn't mention this mild edema of the subcutaneous tissue and the gluteus, the gluteal, the buttocks on this patient. This is related to the clothes and the prolonged bed rest. So this isn't really a issue. This isn't related to the disease we are reporting. So this doesn't need to be reported. This is just a regular thing we see on almost all patients in this setting. So this isn't disease, we are not reporting it. So let's just summarize the report to make it easier for the referring physician. I'm going to add that there was a sequence, a contrast enhanced sequence, because even though it didn't help us much, no, there is thickening of the yellow ligaments. Just copy and pasting to make it faster. All right, here, and we are done. We are done. Another spine MRI scan that has been delivered. Signed off. The cache has been cleared. So let's go for a new exam. We have here a brain scan of a 36-year-old male patient. It has been done with contrast enhancement, so this is a very young patient and there was contrast enhancement. I wonder what was the motive for this case. Let's see, clinical history. It says he has epilepsy. He has been presenting seizures. He has seizures. Has had 3 small seizures, has no headache, and he feels some odd feelings in his superior limbs, and this is extremely awkward. So let's look for any signs of disease that could justify a very young patient presenting with newly found seizures, newly presented seizures. So seizures, convulsions, epilepsy might be related to tumors, intracranial tumors, but no headache and a brain tumor, that's really unlikely. So this is a sagittal T1 acquisition. Fluid is dark and fat is bright, and we can see grayish gray and grayish white as white matter and cortical matter. Gray and white matter are actually gray and white. So, and this is a coronal T2 scan. I don't understand why they did this, but let's get a flare. So a flare is a T2 weighted sequence that has a additional inversion recovery pulse to saturate normal brain fluid. So normal brain fluid is black, and any disease should be bright. So this is great to look for pathology, but isn't that great for morphology. So for morphology we go for the actual T1 and T2 sequences. There is a tiny bright signal here and there. This is very odd. This could be just acquisition artifacts, but I might just report it as a subcortical, tiny subcortical areas of bright flare, T2 flare signal intensity spots. Is there anywhere else? Right here on the frontal pole, bilaterally. Now this is artifact. This is an actual bright spot. This could be just constitutional. It doesn't need to be related to disease. So let's grab a T2. There is a right-sided sphenoidal acute sinusitis, which should represent a very common cause of headaches, but this patient says he has no headaches. Again, I think this isn't true. Patient indeed has headaches. He just said he doesn't. Who doesn't have headaches? Come on, everyone has headaches. Sometimes we have so much headaches we just get used to having them. So the bright spot is here. It is persistent both on flare and T2 as expected. This is on the insular region and on the frontal lobe. So on the margins of the lateral cistern. Excuse me. So let's go for a susceptibility artifact weighted sequence to look for anomalous crystals, minerals, or blood deposits. No such thing. That sequence is fine. no signs of acute nor chronic bleeding. They did a very odd axial oblique hippocampus acquisition. It shows nothing. This is a IR, a inversion recovery sequence that highlights cortical matter and white matter, so it has a greater gradient, a stronger contrast, so we can see and measure much easier, in a much easier manner, any disease that is located on the subcortical or the cortical brain parenchyma. So it really isn't much. They also made the same sequence for the hippocampus on the coronal oblique view, which is much better. And the hippocampus are fine. Let's see. Parahippocampal gyri are normal. Also the temporal lobes, as much as we can see here, are both symmetrical and preserved. This is fine. So we have the post-contrast phases. Let's see if there is anomalous contrast enhancement on those particular foci that were right here on the left insular region. No anomalous contrast enhancement on this axial pre and post contrast phases. So no signs of tumor, nor thrombosis, nor infection, no thickening of meningeal regions, meninges. No. As a volumetric gradient echo axial 3D post-contrast acquisition sequence also. This is much more noisy, but it's a volumetric sequence, so it's cool, especially for vascular diseases. So let's look at it very carefully. Now, no thrombosis, no enhancement, no signs of disease whatsoever. So where is the diffusion? I need a diffusion sequence. Come on, no diffusion. Right here, diffusion weighted sequence is for a ischemic lesion or a tumor or a abscess or a hypercellular lesion of any kind. So diffusion weighted is also weighted for as it's also right when a lesion is spotted, so we should look for bright spots as you do on T2 and flare sequences. So diffusion is fine, that those small tiny bright spots on the left insular region are really there. So let's just compare to this particular ADC map to see if something shows. No, the ADC map is as gray as it gets. No black spots, no areas of concern. So we don't really have much here. We can't really tell why this patient has some kind of new epilepsy or seizures. We are going to report this, but this shouldn't be of much concern. This should be related to some kind of inspecific, mild, really tiny demyelination or gliosis that is quite common and so often asymptomatic. So let's just describe it, because as you know, this and any other exam just won't report itself. So let's grab a template. Template has been pasted, and I'm just going to report those tiny bright spots. So this is it. Just going to summarize. And we are done. Great. The cache has been cleared, and we have returned it. So let's grab a dorsal spine MRI scan. Dorsal or thoracic spine. This is a woman, a 58-year-old woman, and she says, I'm just going to download it, and she says she has, let's see, why is she going through this exam? She has a very severe and persistent pain on the chest or the thoracic region. So it's a painful spine. Let's load the images. Dorsal spines are usually the best exams. They're usually very noisy and shaking exam, because the heart is right here, the patient is freely breathing, so it's going to be shaky. This patient is quite chubby, she is obese, clearly obese, so it's always difficult to do any exam if the patient is larger than normal. But this is quite nice. This is a very nice exam. Let's grab a template. I have already seen a few signs of pathology. I don't know if you guys have. And I just remember this is a great time to hit that like button and consider subscribing to the channel. Thank you so much in advance. And if you must, share this content with people you know enjoys diagnostic radiology. So these are the vertebral elements, the bodies and the posterior elements, the neural foramina, the vertebral canal, where the spine medulla is actually there. This is a T2 because fat is bright and spinal fluid is also bright. And this is a T1 because the fluid is dark and the fat is bright. So you will eventually get used to it, and just by looking at it you are just going to know which sequence is which. So I can see there is a small disc protrusion, a tiny bulging disc on this segment that has no neural repercussions whatsoever. Also, this is the last rib. This should be D12, and I think there is also a small protrusion right here that once again has no neural repercussions. There are some tiny osteophytes, anterior and lateral osteophytes. Also, these facet joints are a bit hypertrophied, sclerotic, and do present with irregular contours, which translates into mild arthrosis. Let's just throw a stir image here. This is a T2 image that has a inversion recovery pulse to make it all dark, including fat, and the only parts that aren't black are lesions and fluid. So this is a fluid oriented image that has a fat saturation additional pulse. So you can easily see the bulging disc right here and a probable bulging disc right here. I can't really tell. I don't know. This is difficult. Maybe here. I don't know. Let's go for the axial view. Usually, dorsal spine is scanned on the axial view in two planes, first half, and in two sequences, in two moments, in two different orientations. The first acquisition is from top to middle, and the second is from middle to bottom because of the normal kyphotic, the normal curvature of the spine. So this is makes the axial view a bit more anatomical. So there are no protrusions, no bulging discs. There is a mild arthrosis indeed on facet joints, and let's see. Oh, excuse me. Oh, I'm sorry. Yeah, just a tiny, very small bulging protrusion right here. We're going to count that segment in a minute. Don't worry, I have to say which segment is that because I'm gonna report that. So I don't know, is this bulging? I don't know, might be just me wanting to report it, so I'm going to leave it aside. There is really arthrosis here, so there is mild arthrosis. Also, the chondrovertebral joints are also a bit deformed with signs of arthrosis. So actually, yeah, there is arthrosis right there. So let's count. I can see this is the first rib, so this is the first vertebra, and our disc is right here. So first rib, first vertebra. This is 1, 2, 3, 4, and 5. So the bulging disc is D5, D6, and we are done. Let's go for the report. Small anterior osteophytes. mild chronic degenerative dehydration of the vertebral discs, because they are reduced in height and in T2 brightness, T2 signal intensity. This is very dark and should be almost as bright as this one. So and there is a protrusion on D5, D6, right? 1, 2, 3, 4, 5. It's focal and central. Very small protrusion. And there is arthrosis. Costal vertebral joints and basic joints. Now let's summarize it. Was there a contrast enhancement phase? No contrast enhancement. Fine. And osteoarthrosis. And this is it. So if you enjoyed this video, I'm pretty sure you're gonna enjoy this next one. Just click here and keep watching. And of course, thank you so much for watching. Hit that like button and consider subscribing to the channel. Please share this video with people you know enjoys diagnostic radiology. And until next time, take care.